Thank you for joining me for a conversation on current concepts in MS, the diagnosis and treatment. I'm Dee Silver. I've been at Scripps Memorial Hospital, La Jolla, California for over 40 years. I'm a medical director of the Parkinson's Disease Association in San Diego, and I'm at Coastal Neurological Medical Group. I put my website on here, so if there's any time you want to visit it, there are articles in there about neurodegenerative diseases, MS, Parkinson's, and others. The outline for our MS talk tonight is going to be in two parts. Part one, we're going to deal with epidemiology, signs and symptoms, and pathophysiology. Then part two, we'll deal with the treatment formats. We're going to first talk about disease-modifying therapy, the immunomodulators, and we're going to discuss efficacy, safety, and tolerability. And then we'll discuss the disease-modifying therapies of the immunosuppressors. And we'll go over the efficacy, safety, and tolerability. And we will deal fairly carefully with how we monitor if a patient is suboptimally treated or if they are having a progression of the disease. We'll go over an algorithm and what I think we should do when we deal with various types of MS. And then I'm going to briefly talk about future drugs. So what is the epidemiology of MS? Well, there are 500,000 people in the United States with MS, multiple sclerosis, and there may be more that are undiagnosed. There are 3 million people in the world, and probably others, with multiple sclerosis. Now, 2/3 of these patients have the onset between the ages of 20 and 40. And the average age of onset is about 24 years of age. So this is a disease that's a neurodegenerative disease, an immunological phenomenon related to a disease, and it is one of the most disabling diseases of the younger age people. The ratio for females to males is about 2-to-1. Caucasians are more likely to have the disease, and people from northern areas of the United States, and they have a higher incidence in European descent patients. This graph shows us a measurement that we use commonly in determining where the patient with MS is in their various stages. And we call it the EDSS, the Extended Disability Scale. And it assesses the course of the disease. And you can see it looks like a ladder. And this ladder starts at the bottom when the patient has a rating of 0, normal neurological exam. And it gradually goes up the ladder. For example, at 2, there's impairment that is minimal on exam. But at 4, the impairment is relatively severe. And a big marker for the EDSS is the number 6, because now the patient has to have some assistance in their ambulation or in their gait. The natural history of MS is very important, and it's a disease of relapses or attacks and remissions, meaning clearing of the symptoms. There's a variable degree of recovery in these patients, and 25% of the patients who have a relapse and start to recover, 25% of them will have 1 point increase in their EDSS, and 50% will have a 0.5 increase. So the idea is that in remissions, not everybody completely goes back to baseline. Now, the MRI is a very important test, magnetic resonance imaging, and it's very important for helping clinically associated lesions that occur with clinical events. And for every 1 clinical event that takes place, and you see an abnormality on the MRI, there are 5 silent lesions that can occur on the MRI without obvious clinical symptoms or signs. Most people with MS go on to secondary progressive MS. Hopefully we're changing this some with our disease-modifying therapy. But most of them go to what we call secondary progressive MS. The average onset is usually after the patient has had MS for at least 11 to 19 years. Now let's look at a slide that shows us the 4 types of MS. And remember, there is a relapse or an attack that gives us what we would call a new clinical event. It's a period during which the patient's symptoms worsen or new symptoms occur. On the upper left part of this graph, you can see RRMS, and that's relapsing remitting multiple sclerosis. In these patients that have relapsing remitting MS, we see from the graph that they have an event that carries them above baseline, and then when they remit, most of the patients go down to the baseline, so they have no significant residual. But their next attack or relapse occurs again, they have more symptoms, and if it's a mild one or they go back to normal, they go back to normal. But fairly commonly, they'll have an increasing amount of residual or accumulated neurological deficit. And this accumulated neurological deficit is seen in secondary progressive MS. We have a relapse, the bar is above the baseline, they may go back to baseline, they have another relapse, but from that time on, they acquire accumulating neurological deficit, and they march up that ladder of the EDSS scoring system. On the bottom left-hand side, you can see PPMS, and that's primary progressive MS. And those patients seem to creep up with neurological impairment, progressive neurological findings, and their disease continues to increase with ever progressive residual. Those patients usually don't have any relapses. But there is a form called progressive relapsing MS that occurs where the disease starts off with progression, and then as you go up that ladder, they have a relapse and they may get better, but they continue to get worse. Now, what's the clinical diagnostic criteria for definite MS? Well, it's changed significantly over the years. When I was first seeing patients with MS at the University of Iowa in the late 1960s, we used the criteria of relapses and remissions with multiple anatomical sites. And you determined the multiple anatomical sites on the basis of the exam or the neurological exam. Then Poser criteria came about in 1983. And that criteria for making the diagnosis of clinically definite MS, knowing that we didn't have a marker, was 2 attacks with evidence of separate lesions by history or by exam. But later, McDonald criteria came about, and it incorporated the MRI. The MRI came about in about 1982-83. And with that information and with the lesions, we put that into the established diagnostic workup, and we fine-tuned our criteria. And the first McDonald criteria came out in 2001. It was changed in 2005, and then it was revised in 2010. So it used the criteria of the MRI and the history and physical that gave us the idea of multiple anatomical site involvement with relapses and remissions. And then much later, we started to incorporate other tests such as spinal fluid and other refinement of MRIs. So today we think of the diagnosis as any 2 lesions in space and any 2 in time. And we can use the MRI for that, which helps, and we can also use the clinical history and exam. So it's any 2 and any new. Now let's talk about the MRI. It seems unusual that we should talk about a test with patients and some doctors about exactly what the MRI findings are. But as we refine our therapeutic management with all the new drugs that are coming in, we're going to have to think about the MRI as a marker for MS, whether the patient's suboptimally treated or whether they're having a non-responding situation clinically. So the MRI scan in multiple sclerosis has lesions in certain areas, which I'll show you. But they're paraventricular, they're juxtacortical, meaning it's next to the cortex, cortex. They're infratentorial, below the tentorium, in the brainstem and the cerebellum. And in gray matter, which we now realize really has significant lesions, and in the spinal cord. So let's talk about three important characteristics of the MRI. And this is somewhat sophisticated, but it's important to remember. We have the T2, the T1 that's non-enhanced, and we have the T1 that's enhanced. When you have enhancement, you get an IV dye that helps enhance certain lesions. So let's look at T2. Well, in the T2 MRI, the spinal fluid and the T2 lesion is white. And it indicates inflammation and or edema. It indicates demyelinization and or scarring. And it indicates axonal loss. For years, we wasn't sure whether axonal loss took place. But now we know axonal loss takes place very early, and it takes place in T2 lesions. Then the T1 non-enhanced MRI picture shows the CSF, or spinal fluid, and the lesion is gray or black. And it indicates demyelinization and or gliosis, and it's long-term gliosis, or been there for a long time. It looks like a chronic black hole. And axonal loss is present within and outside the lesion. And then the T1 enhanced lesion, with contrast, the spinal fluid is black and the lesion is white because it takes up enhancement with the gadolinium, and it indicates there's a significant amount of acute inflammation and a breakdown of the blood-brain barrier. Three important things which I'm now going to show you on the conventional MRI in multiple sclerosis. So we take this MRI and we correlate it with the clinical picture. So in the upper left-hand side, we have the T2 picture on the MRI. And this oftentimes we think of as the burden of disease that takes place. And you can see on this MRI, the spinal fluid is white, but you can also see that in the upper left part of this picture, which is really the right-hand side of the brain, that there is a white area above the ventricle, and then on the other side of the ventricle, there are small little white dots, and those are T2 lesions. And there's some around the other ventricle and some out in the periphery. Now the T1 gadolinium post-contrast picture is on the right upper side. And you can see there the spinal fluid in the ventricle is dark. And you can also see that those white areas surrounding the ventricle on both sides, at the top of the ventricles and at the bottom, are gadolinium positive lesions that indicate active inflammation or indicate breakdown of the blood-brain barrier. And when the blood-brain barrier breaks down, that means there's a significant amount of inflammatory cells that can get into the brain. Now in the bottom picture is the T1 without contrast or pre-contrast picture, and it indicates hypointensities. Now these hypointensities are very important because if they're acute hypointensity, they may resolve. About 50% of them will resolve, and they'll either go to a T2 or a T1 lesion, or they will go back to no lesion at all. But then many of them will develop and stay as chronic black holes, and that means there's significant axonal loss. And most people believe that it's the black holes that suggest the correlation best for progression of disability, correlates best with cognitive abnormality, and it indicates the most severe tissue destruction and axonal transection. Now this is another picture that shows many lesions in the brain. The white ones, they're around the ventricle, as you can see where the arrow is placed, but there are also some peripherally and some around in other regions. And this would be considered to have a significant amount of disease burden. Now let's look at a slide that shows us the histopathological correlation of black holes, because black holes oftentimes means there is significant disruption of the axons, or there is axonal breakdown or axonal segmentation. Now the picture of the MRI on the left, you can see the black holes. They're juxtacortical, they're near the cortex, and there's some that are deeper. So what our slide shows on the right is the percentage of axons that are transected that are present, but really the percentages relate to the percentage of axons that are still intact and aren't transected. On the bottom, this is normal white matter, and there are 100% of the axons that are present. And you can see the density is even more in the normal area. But number 2 shows mildly hypointense black hole. It correlates with that. And there is 60% now of remaining axons, meaning 40% are actually transected. And the top one shows the most dense hypointense lesion, and there are only 20% of these axons that are remaining. Now let's switch gears and talk about clinical syndromes. And we're going to start with the first one that oftentimes is picked up, and it's called the radiological isolated syndrome. And what it means is the patient has no symptoms, or they don't realize the symptoms, and the doctor doesn't pick up the symptoms on a clinical history or on any exam. So the MRI is done oftentimes for some other sign or symptoms that are not specific, or it's done in the ER in the office for things such as headache or head trauma or cranial head trauma or traumatic brain injury. And the symptoms really do not fit with a symptom that would sound like MS. And these MRIs usually show T2 lesions like we showed you in the slides before. Sometimes you'll see dark holes, but usually they are white T2 lesions, and rarely you'll see an enhanced lesion. So the MRI may fit with MS if there are any 2 lesions in the right area and any new lesion. So this is called the radiological isolated syndrome. And the difficulty with this syndrome is, how do you manage it? And if there are MRI lesions that fit with MS, do you start to treat these patients? And in my opinion, sometimes I will do that. Now there's another syndrome called clinically isolated syndrome. We talked about radiological isolated syndrome, but this is clinically isolated syndrome. And it says exactly what it means. One clinically isolated event where the symptom that occurs may fit with the history of MS, and one clinical event by history is known. And then you get the MRI, and the findings are there, and they're in the appropriate areas. They may be T1, maybe T2 lesions. They're usually paraventricular, juxtacortical, infratentorial, or rarely in the gray matter or in the spinal cord. Sometimes they can be seen in the spinal cord. So again, you have a clinically isolated event, and the MRI helps us that there is 2 lesions on MRI, and one may be new, and we talk about that as any 2, any new lesion. So what are some of these symptoms that can actually occur with MS or multiple sclerosis? Well, let's briefly go over these. And they may be part of it. Some of them are more classical than others. Walking problems can occur, maybe the very first symptom. Difficulty with coordination of the arms or legs. Balance problems, sometimes early falling, bumping into things. Depression is very common in MS. It's thought that 30 to 50% of the people with MS may have depression before the diagnosis and 50 to 70% after the diagnosis. So depression is very important. Emotional changes can occur other than depression. And sometimes that is personality changes or excessive laughing or excessive crying that can occur, and we call those pseudobulbar affect. Dizziness and vertigo can occur. Sexual dysfunction. Fatigue is very common in MS. It's thought that 50% of the patients with MS can have fatigue prior to the time they're diagnosed. And it's thought that 70 to 80% of people can have fatigue when they have the diagnosis and as the journey of MS continues. and oftentimes it is significantly impairing. Now, pain is not uncommon, and oftentimes you can't localize it, but sometimes it can be what we call radicular, or it can be in the face. So pain is not uncommon. Changes in cognition or cognitive function or memory is very common in patients. And it's thought that it can occur sometimes before the diagnosis, but after the diagnosis, studies show that some cognitive impairment can occur in at least 2/3 of the patients when they have the disease and when they have their journey with their disease process. Visual difficulty can occur, and optic neuritis can oftentimes be a presenting symptom or occur early in the disease. And that is an event where the patient has an episode of loss of vision. The patient complains they don't see anything. They may have pain with that visual loss, and the doctor looks in the eye and he doesn't see anything abnormal, and the optic nerve looks normal. Later on, that optic nerve will show atrophy. Numbness can occur in any arm or a leg, and not uncommonly it can occur below the thoracic area, in the chest, or in the thoracic area, or in the abdomen, or in the legs. Bowel and bladder symptoms can certainly occur, and spasticity or difficulty walking. So now let's look at a patient profile. And this is from one of the standard lecture series from a drug company, and I have borrowed that. And let's look at this profile and analyze it, how the patient goes through their journey of MS. And it has a way the patient's been treated, but I'll tell you as we go through the profile how I would do this, and probably many other people would. So we have a 21-year-old right-handed female. Remember, females are more likely to have MS. And this patient has come into the doctor because they've developed a painful visual loss in their left eye. And this is optic neuritis. Now, in a careful history, the doctor picks up that a year ago, 1 year before this, the patient had an episode of numbness in their right leg lasting for 3 weeks. Now, when the neurologist at that time, a year ago, confirmed that he found that there was increased reflexes in the left arm. So if you look at this, right arm numbness and left arm increased reflexes, or increased spasticity maybe, would indicate there are probably 2 lesions. Now, at that time, that neurologist did not get an MRI or didn't treat. Now, in my practice, retrospectively, not being critical, but I would have gotten an MRI thinking that there were 2 lesions that were present, and if there were lesions on the MRI, I would have probably started the patient on a disease-modifying therapy, either on any of the drugs, the interferons. We could use Avonex, Betaseron, or Rebif, or you could use Copaxone. But that would have been my thought. So at this time, with the patient now having a bout of optic neuritis, a year later, the scan was abnormal. And you can see on the right that the scan has T2 lesions, little white areas, along the ventricles, one on the right side of the picture that you see, and also some around the frontal area. So now there is a significant number of lesions, and importantly, this patient's scan is abnormal. Now, the doctor decided to treat the patient for optic neuritis with steroids. And the steroid treatment was probably methylprednisolone, maybe prednisone, and everything resolved in 3 weeks. And the doctor did not use any disease-modifying therapy that I mentioned before. I would have aggressively treated that patient because, as we'll show you in this overview of MS, that early diagnosis and early treatment is very important for reducing the progression of the disease, in my opinion, and reducing the burden of the lesions on the MRI. So the doctor watched the patient after he treated with steroids, and the patient did get better, and the patient did well for 10 months. But then the patient had their 3rd important bout. And the bout was that of right facial numbness and tingling, vertigo, and an unsteady gait. Now, from those three symptoms, you know that there were multiple lesions in the brain. So there was a repeat MRI done. There were two new lesions, or new lesions appeared in the pons area, and there were probably more lesions than that. And a cervical MRI was done that was normal. So the doctor decided to treat with Avonex. And Avonex is the interferon beta 1A that's given once a week, IM, and this patient was treated with Avonex. Now, I probably would have used another drug, but Avonex could be used. So it's ongoing disease-modifying therapy. It's an interferon, and then after 9 months of treatment with Avonex, the patient experienced a difficulty with gait disturbance and right leg paresis. The brain MRI shows more lesions that are non-enhancing, but now the patient has, as is demonstrated by the picture on the right, a lesion in the spinal cord that is enhancing. And you can see, as the arrow points to, the area at about C4 where there is this white area. And it takes up much of the spinal cord, and that is a enhancing lesion that's done on a T1 imaging, and you can see that's an important lesion. So in review on this patient, in my opinion, there should have been an aggressive treatment earlier with disease-modifying therapy. This patient probably had the unfortunate experience of accumulating lesions in the brain and the spinal cord, and now the patient is in difficulty. And the case now, after this problem of all these new lesions and in the spinal cord, you would have to go to another drug, probably not an interferon, maybe Copaxone, but you'd think maybe about fingolimod or natalizumab or teriflunomide. So my algorithm for the treatment of MS, I will give you my thoughts and we'll review it a little bit later. So here's my treatment algorithm. For radiological isolated syndrome, I would try to determine the diagnosis, and if there are lesions that look like on the MRI it is MS, I'd do a spinal tap, looking for abnormalities like oligoclonal bands, and I would probably treat the patient if there is gadolinium-enhancing lesions, and there is no other cause for those. And if I didn't treat it, I would definitely follow the patient closely and repeat the MRI. For clinically isolated syndrome, I would aggressively treat these patients, and I'll show you some studies that show that that's the case. The studies on the CHAMPS trial showed that it was important to diagnose early and treat early, the BENEFIT trial and the PRECISE trial. Then patients that have relapsing remitting MS, I would aggressively treat them with immunomodulators, disease-modifying therapies, with close follow-up. If they're stable, I repeat the MRI in a year. If there's any changes, especially gadolinium-enhancing lesions, I'd probably change therapy. And I'll show you a slide that shows, importantly, that if T2 lesions are accumulating in number, you want to think about changing therapy. And then if there is relapsing remitting MS and it's gradually getting worse and there is frequent relapses, higher burden on the MRI, I would go to a more aggressive therapy, maybe immunosuppressive therapy like natalizumab, fingolimod, or teriflunomide. And for relapses or for adjunctive therapy, I would use methylprednisolone or Actar in a relapse. Now let's look at this very important diagram that gives us a natural history of MS. This diagram is a little complex, but it's an important one for us to understand, for patients to understand and doctors to understand. Now this diagram shows a concept of the preclinical phase, relapsing and remitting phase, and secondary progressive phase. There are 4 important key color indicators here. On the left side, the white shows us the measurements of brain volume. And as you can see with the white line, as you go through the phases and secondary progression, you're getting more brain atrophy or loss of brain volume. As you go through the blue line, you can see that in the preclinical phase, because you can't make the diagnosis yet, very easily. You have no episodes of relapses or remissions. But then the first bout, you have a relapse. You go up from the baseline, and that relapse lasts for a period of time, has to be longer than 24 hours, and then hopefully with therapy, it goes back to baseline. As you go through relapsing and remitting, then you get into secondary progressive, and the blue line, it goes higher, indicating accumulated neurological deficit. The red line indicates the MRI lesion accumulation. So that's called accumulation of disease burden. And what we have there is that the red line early on gives you some accumulation, and we know preclinically before any event patients start to have lesions. And they have MRI activity as shown by the yellow arrows. But when the relapsing and remitting phase occurs, the accumulation of the burden on the MRI increases. There's frequent MRI activity, and when you get into secondary progressive phase, where there's accumulated deficit, there is significantly more MRI lesion accumulation, and there is less MRI activity. But axonal abnormalities and breakdown and transections continue. Now I'm going to briefly show you some slides on clinically isolated syndrome. And what we think about in these clinical trials is how can you affect the delay to development of clinically definite MS? Because we know that's important. So this slide is on the benefit trial in beta-seron, and on the vertical is the percent of clinically definite MS, and on the horizontal is the number of years. So in this group, these patients on this blue line got beta-seron immediately when they were diagnosed and when they were put into the trial. And you can see that 37% were clinically definite MS at 3 years. And at 5 years, it was 46%. Now, in this clinical trial, there was a placebo that was given. And this is an injectable every other day. And so they were injected with a placebo. And that's the white line. And you can see the placebo was given for 2 years. And up is bad as far as clinically definite MS. And so at 2 years, when the placebo was still given, 50% of the patients then have clinically definite MS. And that is significantly greater than when you use beta-seron alone. Then at 2 years, they got converted from placebo to beta-seron. And when that conversion was made, you can see they still had a greater incidence of a higher percentage of MS. So at 3 years, there was a significant difference, 51% for those who got placebo and later got beta-seron versus 37%. And at 5 years, there is still a clinically significant difference. So patients who got beta-seron first did much better. Now, let's look at another way to look at clinically isolated syndrome and its journey. What I'm going to want to look at now is the time to confirmed disease progression, and that's important. So on the vertical, we have confirmed EDSS progression, and on the horizontal, we have years. And we're going to show you the group that got immediate beta-seron, because this is the same study. And at 3 years, confirmed EDSS progression was documented in 16% of the cases, 25% at 5 years. But look at the group that got placebo first, and then at 2 years got switched to beta-seron. You can see that the people who got placebo fared much worse than those who got the drug active from the beginning. And they still didn't do as well after they were switched to beta-seron. So early diagnosis, early treatment is much better. Now I'm going to look at another drug called Copaxone, glutaramine acetate, with the same concept. This concept is using clinically isolated syndrome, and then patients were given Copaxone in one group, and another group was given placebo. And then later on, the placebo group was switched to Copaxone. And we're measuring the efficacy in clinically isolated syndrome. And here, the vertical marks the second exacerbation. So we're measuring from a clinically isolated syndrome to a second exacerbation, or another relapse. And we know that relapses are related to progression of the disease. So second exacerbation or relapse, and you can see the yellow line is Copaxone, up is bad, and the patients with placebo have much greater likelihood of having a second exacerbation. And in fact, it's a 45% risk reduction. So we've shown here in a number of cases, clinically isolated syndrome, it's very important to diagnose early and treat early. And using Copaxone in the PRECISE study, we look at T2 lesions, which I showed you on the MRI. And the vertical here is the number of T2 lesions. And we can see on the horizontal, it's placebo during that time that the patients got placebo. And it's compared to those who got Copaxone. And the number of new T2 lesions was significantly reduced if you used Copaxone early and first. Now, I'm going to develop this concept in the next few slides to give us an idea why it's going to be important to understand MRI changes and why it's important to understand relapses and how that's going to impact on our changing disease-modifying therapy, switching to immunosuppressants if we need to, or switching to other types of medication. So the MRI in this graph shows us that MRI predicts clinically definite MS development. And we talked about that in the clinically isolated syndrome, but now we're looking at the MRI. So the vertical is the percent of clinically definite MS patients, and the horizontal is 5 years. So this is an optic neuritis clinical trial. This measures the amount of MRI involvement and the number of lesions that are present. So these patients with optic neuritis were treated, and they monitored the MRI, and it shows here very clearly that when you have no lesions, and that is the red line, when you have no lesions, your percent of confirmed diagnosis of MS is very small if you have no lesions, 16%. But if you have 1 to 2 lesions on the MRI, then you have more likely chance, percentage-wise, of developing clinically definite MS. And if you have greater than 3 lesions, 51%. So the MRI predicts the development of clinically definite MS. Then let's look at early MRI events that correlate with disease progression. So we talked about development of clinically definite MS. Now we're going to talk about disease progression. And there's 2 graphs here. They're formulated the same way. The vertical is involved with the percent of patients with a certain EDSS after 10 years. So the first group on the left is an EDSS of 3. The group on the right is an EDSS of 6. And if you remember, the higher the number, the more disability. And at 6, you need assistance with walking. So let's look at the group on the left. So we have percentage of patients on the vertical, and we have in blue greater than 10 lesions, and in yellow less than 10 lesions. And you can see your chances of developing disability greater than EDSS of 3 is significantly less if you follow these patients. So the smaller the number, the less chance of developing more disability. And that correlates into if you can get disease-modifying therapy that gives you a smaller number of lesions, your progression will be less. So the one on the right-hand side is the same format, percentage of patients with EDSS, this time of 6, greater impairment. So if they have greater than 10 lesions, 35% of those patients are going to, at 10 years, are going to develop an EDS of 6. And if you have less than 10 lesions, an EDSS of 6 is less common. So you've got the picture. We want to reduce the number of lesions. We want to treat early, after we diagnose early, and keep the disease burden down. So now we're going to talk about clinical relapses. Early relapses affect long-term disability. And this equates to the concept, if you're having early relapses, we want to do something about it. So this graph shows 3 colors that notate the number of attacks. So the vertical there is a percent of patients, and it goes from 0 to 100. And the horizontal is the time from onset of MS that the patient develops long-term disability. So we have the yellow, and if you only have 0 to 1 attacks in 2 years, that's the percent of patients not having reached an EDSS of 6, where they have trouble walking. So you can see fewer patients, if they have fewer attacks, will develop an EDSS of 6. But if you have 2 to 4 attacks in 2 years, that slope shows you that you're going to have a lower percentage of patients that have not reached the EDSS of 6. So when you get more attacks, you're going to have a greater chance of developing an EDSS of 6. And then if you have greater than 5 attacks in 2 years, you have your greatest chance of developing a significant disability. Now, one other thing we're going to look at is brain atrophy and its long-term ability to measure disease progression and symptoms. And on the left, we have the change in the EDSS of patients with these 3 MRI pictures. And they're going to measure different years of time and a greater impairment of disability measuring the EDSS. Now, atrophy of the MRI is oftentimes correlated with cognitive impairment and fatigue, and we also think probably progression of disability. So the first MRI on the left shows us that there's not a lot of atrophy. The atrophy is documented by the ventricles, which are black, and their size. And at 10 years, in this picture on the left, the EDSS is 2.5. The next center picture of an MRI shows at 15 years of disease duration, the patient has an EDSS of 4, fairly significant impairment. And on the right, that there is an EDSS of 6.5. This is a patient that's had the disease for 20 years, and you can see that the black areas of ventricles have had significant amount of enlargement, and that's because there is axonal loss, there's T2 lesions, and there is also gray matter impairment. Let's talk about the association of why patients don't do well with their therapy and why they may be having greater accumulation of disease burden on their MRI or more relapses. And this study was done when someone went ahead and tried to determine the amount of medication the patient had after a period of time that was unused. And what this slide shows is that on the left is a relative risk, that's the vertical, is a relative risk of having a relapse. And the horizontal really indicates the amount of medicine that the patient hasn't been taking, or in this percentage is the 60% that they have left versus on the left-hand side, 85% they have left. You can see from the slide, if they have a lot more medicine left, they have a greater risk of having relapses. So I'd like to look at the suggested indication of suboptimal responses. And what are they? Well, if you have greater than 1 relapse per year, or lack of improvement from baseline after you have 1 relapse, that's an indication of a suboptimal response. If you have incomplete recovery from a relapse, if you have multiple lesions historically, on the MRI or multiple lesions from the exam or history, that indicates it's a suboptimal response. If there's involvement of the brainstem or spinal cord, that's probably a bad sign. And if there's loss of neurological function that disrupts activities of daily living. And some people examine neutralizing antibodies. We're not sure of that aspect. And there are other things that may affect the response to therapy, and that may be non-adherence or sometimes ethnicity. So the measures to verify the changes are: 1, you establish a score that is higher; 2, you repeat the MRI scans; and 3, you rule out other causes that may cause an apparent relapse, such as infections, and you may want to check neutralizing antibodies. So how do we use MRI in MS? Well, we have documented the MRI may predict relapse rate. And on the right-hand side, you can see the predictors. Number 1 is that there may be presence of gadolinium enhancement lesions. The number of relapses may increase over 2 years. The higher the number, the greater the chance of having poor prognosis or suboptimized treatment. And there may be greater number of T2 lesions which are present, and black holes may be accumulating. So we have to repeat that MRI at some time. And this slide shows us very easily in a beta-seron trial that there are predictors of poor treatment response. And these are new lesions on the T2 weighted MRI at 1 year. And on the right-hand side, you can see on the vertical is the percentage of patients, and on the horizontal are the number of lesions that are represented by the bar. Blue is non-responders, and gray is responders. So the first bar is there are no new T2 lesions, and the response of that therapy is good. Then as you accumulate 1, 2, and 3 or more lesions, that there is a greater percent of non-responders. So we do not want to accumulate T2 lesions. So MRI measurements to assess suboptimal response are T2 weighted images, T1 weighted images, and gadolinium enhancing lesions. And just to briefly review, we know T2 indicates inflammation and demyelinization. Enlarging T2 lesions are a bad sign: more inflammation, more demyelinization. And chronic lesions that are T2, been there a long time, really indicate more scarring and gliosis. And the T1 weighted ones indicate acute hypointense lesions, black holes, and they can stay there for a longer period of time. They oftentimes indicate inflammation. Chronic hypointense lesions mean axonal segmental loss, demyelinization, and the gadolinium enhancing one means breakdown of blood-brain barrier and significant activity of the disease. Now I'll briefly mention about CSF biomarkers. We know that the B cell activation really is significant, and that gives us the oligoclonal band production in the spinal fluid. And that may be somewhat of an indicator. I mentioned that that can be obtained by a spinal tap. We sometimes do that in radiological isolated syndrome or clinically isolated syndrome. But it's thought that it can predict the conversion from clinically isolated syndrome to definite MS, and it may correlate with MRI activity, and it may correlate with relapse event. Now, importantly, it is thought that in the future we're going to have many, many more markers, and they're coming soon, but I'm not going to elaborate on that in our conversation on MS today. How can the individual person get involved and allow their MS to do better? Well, one of the most important things is be your advocate, be knowledgeable. We need individual responsibility, and we need to be significant in our educational process. You need to follow your physician, be aware of what your signs and symptoms are, follow closely. We know that if the patient's caregiver response, patient response, and doctor response and other supportive people are all on the same page everybody does better. Education really is a key. We now have nurses that are associated with the drug companies that will help you understand your injection processes and also help educate your family, and there's 24-hour hotlines. So in summary, we've talked about a suboptimal response to the disease-modifying therapy may contribute to the changes in relapses, their rate and severity, MRI activity, and disability. You want to diagnose early, treat early. We know patient factors are really important. Adhere to the therapy. If you have trouble with it, get a hold of your doctor right away. A second opinion is never a bad idea. It's sometimes very beneficial. And work with your caregiver, and for doctors, you have to coordinate the care. It's important to remember the patient may not always display or have symptoms that fit with clinical aspects and MRI relationship. So they may not have clinical symptoms, but the MRI has this constant ongoing activity. The pathology of MS is continuous, and it usually leads to permanent disability. And I want to just go over this somewhat. We don't want to make you an expert in MS, but you should have some kind of idea. We know that MS is an autoimmune disease. It's an inflammatory activity that goes on in the brain, and there's demyelinization and axonal loss. We know that this occurs, and it occurs because of inflammatory cells. We know inflammatory cells cross the blood-brain barrier. We know that this pathology is ongoing, and we know that it occurs prior to the symptoms, and we know that it is a constant evolving process. We need to think of these things as markers to help us how to treat the patient. So along the top, we see we have a T cell. This is a pro-inflammatory T cell. It gets into the brain, goes through the blood-brain barrier, and it releases cytokines, or substances that attack the axons and also attack the myelin. So it gives us axonal transection and demyelinization. And you can see that on the MRI. The next slide shows us some microscopic pictures of, on the left, axonal transection or axonal bulbs that are stained, and this indicates here significant axonal loss. And we showed you some of that on a different slide. And on the right, the green shows little lines of areas where there's demyelinization. So this is an ongoing process in the MS plaques. And it also occurs in areas around the plaques. We've talked about MS today on this very aspects of what we can do to help the patients, how physicians can understand this important disease that has an autoimmune basis, where it's very important. We want to make the diagnosis early, we want to make the correct diagnosis, and we want to treat early. And we've covered many of the aspects of MRIs and relapses and how they play a role in our treatment of patients with MS. This series of programs has been funded by the generosity of the Bell Foundation in honor of Glenn W. Bell Jr., founder of Taco Bell, and by Elaine and David Darwin.